So we discussed in detail about the what is amebiasis, what are the different organisms causing the amebiasis. It's all the Entamoeba, mainly was Entamoeba Histolytica. Then we talked about dispar and other type also, and how it developed, what's the life cycle and transmission, what's the pathology and pathogenesis, how the proteases function as a virulent factor, and how the immunity develops. So we talked that in detail. But in the last section, we will discuss the treatment options available for amebiasis, and also the lab diagnosis of amebiasis and serology and radiology. So lab diagnosis, stool examinations, and then we have a serologic test for the identification of amebiasis. Non-invasive imaging of liver. Fecal findings suggestive of amebic colitis. Positive test for heme in the dysentery. It has little stool specimen and more mucus and blood is present. So stool or fecal specimens are positive for the heme or blood. You can see in this slide also positive for blood. A paucity of neutrophils are also present because of all the infection that's going on. Amebic cysts or trophozoites, which are released in the fecal matter and then ingested, and that's how the whole cycle starts. So there is presence of amebic cysts and trophozoites in the fecal matter. Definitive diagnosis is by the demonstration of hematophagous trophozoites of Entamoeba histolytica. So presence of trophozoites of Entamoeba histolytica is the significant diagnosis. Examine at least 3 fresh stool specimens. Examination of a combination of wet mounts, iodine stain concentrates, and trichrome stain preparations of fresh stool. Concentrates for cyst or trophozoites. Culture of amoeba. So all these are the definite diagnosis for the Entamoeba histolytica infection, presence of trophozoites. We should examine at least 3 fresh stool specimen, a combination of wet mounts, iodine stain, concentrates, trichome stain preparation of fresh stool are also the definitive diagnosis, and also culture of amoebas from the stool specimen is the definitive diagnosis of the amebiasis. Sigmoidoscopy with biopsy, examination of the sigmoid colon and getting the biopsy from that of the edge of ulcers may increase the yield of dangerous during fulminant colitis. If the fulminant colitis is present, we should not do sigmoidoscopy because it can be dangerous and can cause perforation. Risk of perforation is present. Trophozoites from a colonic mass, this you can see the colonic mass, so we can have isolation of trophozoites, confirm the diagnosis of amoeboma. Rare in liver aspirates, found in abscess capsule, and not in the readily aspirated necrotic center. So trophozoites, if they are obtained from the colonic mass, it's the significant of amoeboma, and it is helpful in the diagnosis of amoeboma. Trophozoite may be confused with neutrophils. Cysts must be differentiated morphologically from Entamoeba, Hartmanni, Entamoeba coli, and Endolimax nana. Cysts of Entamoeba Histolytica cannot be distinguished microscopically from those of dispar and moshkovskii. So, microscopically, it's hard to differentiate between the cysts of these three types of Entamoeba. Detection of galnac-lactine of Entamoeba histolytica, by which it attached to the epithelial cells of the mucosa. In terms of sensitivity, compare favorably with polymerase chain reaction. With isolation in culture followed by isoenzyme analysis. Now, the serology study of the serum is enzyme-linked immunosorbate assay, ELISA. We have agar gel diffusion assays, positive results in conjunction with the appropriate clinical syndrome. Findings revert to negative within 6 to 12 months. Indirect heme agglutination test, more difficult because titers may remain positive for as long as 10 years. Radiographic studies, radiographic barium studies, potentially dangerous in acute amebic colitis, again because of the danger of perforation. Amoebomas identify first by barium anema. Biopsy for differentiation from carcinoma, because amoeboma it's also present with the mass-like growth, and the carcinomas can also be the growth, so we need to do the biopsy for differentiation. Radiographic studies, again like ultrasonography, you can see the presence of abscess. CT and MRI. Differential diagnosis of amebiasis is bacterial diarrhea caused by Campylobacter, entero-invasive E. coli, species of Shigella, Salmonella, and Vibrio. All these are very common organisms, causes the intestinal infection like Entamoeba histolytica need to be differentiated. So Campylobacter, Vibrio, Salmonella, Shigella, and E. coli. Typical patient with amebic colitis, less prominent fever, heme-positive stool with few neutrophils, bacterial cultures, microscopic examination of stools, and amebic serologic testing. Amebic liver abscess confused with pulmonary or gallbladder disease, any febrile illness with few localizing signs. Next, we have treatment, conditions, and therapy. Asymptomatic carrier, luminal agent like idoquinol, 650 milligram tablet, TID for 20 days, or paromomycin 250 milligram tablet, 500 milligram TID for 10 days. Acute colitis, metronidazole 250 or 500, 750 milligram per oral or intravenously, also luminal agent as above. Then we have amebic liver abscess, again metronidazole, very effective orally or intravenously, and then luminal agent. Metronidazole, long-acting nitroamidazoles like tinidazole and or nidazole, single-dose therapy can be used. All treatment should include a luminal agent. More than 90% patients reported respond to metronidazole therapy within 72 hours. Indication for aspiration of liver abscess: need to rule out a pyogenic abscess in patients with multiple lesions, lack of clinical response in 3 to 5 days, threat of imminent rupture, and need to prevent rupture of left low abscess into pericardia. So all these are indication when we need to aspirate the abscess of the liver. Prevention: adequate sanitation and eradication of cyst carriage. Avoidance of unpeeled fruits and vegetables. Use of bottled water. So unpeeled, usually there may be more chances of contamination by the cyst. Use of bottled water. Disinfection by iodination. All these are the preventive methods that can help us to prevent the spread of infection. So that concludes our topic of amebiasis. Thank you for watching sqadia.com.